Okay, so I am going to switch to speaker view, and I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. I have great pleasure to introduce a friend and colleague who I believe is one of the great leaders in joint arthroplasty in this country. That's Jess Lonner, who is now at the Rothman Institute, who wrote an article for us on his personal journey through three phases of robotics. I have to say, I talked to him beforehand. I thought it was the most well written article we've had, the most literary, um, and was really an eye opener for all of us who are interested in this. Jess, could you just say words about introduce yourself, and then I'll ask you some initial questions and stuff?
Sure. Hello, everyone. Jess Lonner. I've been in Philly now practicing for 25 years. I really only do knee replacements on an elective basis. I gave up my elective hip practice probably close to 20 years ago, and I got interested in robotics about 15 years ago. So it's been now a large percentage of my adult career that I've really been interested in robotics. And as you'll hear tonight, I've gone through several iterations during the process. So I'm happy to share that with you.
It's incredible. One of the first questions. This article, by the way, got over 3,500 article views, which is really remarkable. I think it beat Harry Potter, the fifth book, Order of the Phoenix, by about 6 views. Um, but I
I'm
will
still
say,
waiting on my royalty check, by the way.
yeah, okay, yeah, it's in the mail. Yeah, we got that. I got first question always is what when you are just such an early adopter in this, what thought processes did you have 2012, 2013, during that time period to make that jump when other people were really using jigs from 20 that were 20 years old?
Well, I'm really not a technophile. I've become one, but I didn't grow up as a technophile, and I think for me it was more of a curiosity. I think I was introduced to Martin Roach, who was working with the folks down in Florida at Mako in around 2006, and Martin knew I was doing a lot of partial knees, and they were working on this new, crazy, newfangled technology, and he wanted to show it to me. I had no idea that I'd be so impressed as I was when I initially saw it. But basically, that kindled this tremendous interest in using this sort of technology initially for partial knees, unis, not patellofemorals,
Right.
and then eventually for total knees. But it caught me by surprise. I didn't think that robots were really something we would ever see in our orthopedic lives until I was introduced to a robot back then.
Right. Now, how many you in the beginning? I remember Mako was primarily unis, right?
Yeah, that's right.
And I personally recall doing a lot of unis in my private practice. Just using jigs and other things like that. What advantages do you think you currently are seeing in your practice using robotics?
Well, the first thing I noticed long ago was the improved accuracy of bone cuts, precision of bone preparation, and probably maybe more importantly was the ability to quantify soft tissue balance.
Ah,
So I really only got into robots for total knees a year and a half ago. So for almost a full 14 years or 13 years, for me, it was just about using the robot in my unis.
Right.
And for that, I really saw improvement in alignment, reduced outliers. And then we started to see some functional improvement in both our studies and some other studies with unis.
Right.
And there's some registry data now that suggests that, at least in the hands of the masses, this technology, this class of technologies, may improve durability. Now, that may not be true for total knees. That data still remains to be seen. But at least for unis, it seems that in the hands of the masses, particularly low volume uni surgeons, it can neutralize the effect of inexperience,
Yeah.
and make that casual uni surgeon an expert.
Yeah, I mean, I think you're right. I think my first uni was, I don't know if you remember the Rapici
Sure.
knee, where it was all done with burr, completely with a burr. And then when they Stryker came out with the EOS knee, all poly tibia with some jigs, I thought it was amazing. Like, wow, we have some jigs now.
Yeah.
And then Mako came out. Yeah,
Well, that Mako's first uni was the Rapici knee.
really, yeah.
Yeah.
So it was an inlay. It was an inlay tibia.
Inlay tibia, which had its own problems. But,
Yeah.
they, even John Rapici was very impressed with the precision, because
Yes.
he even acknowledged that there were some inaccuracies with his ability to do, the unis well each and every time with a freehand technique.
So what I'd like to do is um, get into the nuts and bolts of your three-pronged decision making. You use the Mako, you use the Navio, eventually you use the Rosa, okay? And within all of those was a transition period, what I call the transition decision making period. So maybe you can describe that thought process, that transition from first Mako to Navio, and then from Navio over to Rosa, and then we'll talk about the advantages of what you're doing now. But very interesting. I'm always very interested in the thought processes of when people make decisions to move from one to another.
Well, I started using Mako in 2008, probably first quarter of 2008. And obviously there was a learning curve with all technologies, of course. But what we found is that the precision was achievable right away, even when we were still in our learning curve in terms of developing our surgical efficiencies and workflow and things like that. And I was always very impressed with the outcomes. Clinically, the patients were doing well. My x-rays looked better. The knees felt more organic, I think, because of the good quantified soft tissue balance. And we've seen that with each iteration of robot that I've used. But at a certain point, I became concerned about the CT scans that we had to get for each and every patient as part of the preoperative mapping process.
Gotcha.
I started thinking more and more about some studies that were coming out that showed the harmful effects of even low dose repetitive exposure to radiation.
Mm-hmm.
And I became interested in, looking for alternative interventions should they become available. So this was 2008, 2009. And then in about 2009, late 2009, I was invited to present some of my thoughts about robotics to a private equity company in New York. And I talked about my early experiences with Mako, some of the data that we were presenting and publishing. And during the course of our conversation, I suggested to them that they keep their eyes open for this startup called Blue Belt Technologies. And I had seen a presentation in Pittsburgh in 2007, Tony DeGioia was running a conference in Pittsburgh on robotics in surgery.
Yeah.
And he had different specialists from different surgical specialties presenting their new innovative technologies. And then this CEO of this crazy startup called Blue Belt came and gave a talk on raising money and what their prototype was all about. And he takes out this handheld sculpting tool. It looked like a large, oversized arthroscopic shaver. And I was really intrigued. They were working on an image-free system that did not require a CT scan.
Wow.
And this was all preclinical at this point. Tony DeGioia was actually working with them on this. These were engineers that had come from Carnegie Mellon. And I suggested to this private equity company that they look into this Blue Belt technology. And I noticed the side glances around the room. Clearly, this was a technology that they were already looking into. They eventually bought it, and I was fortunate enough to get involved with them early on and help them to sort of work on efficiencies and workflow, and then help commercialize it. And it was an impressive technology, first and foremost, because it was image free.
Right.
We didn't have to get a CAT scan. But it was also a pretty disruptive innovation because it was going to be commercialized at a far lower cost. It was very portable. We could move it between rooms very easily, and it could fit into a surgery center. And even at that point, in 2011 to 2013, when the technology was still being kind of developed, it was clear that there was going to be a shift, at least of unis, from the main hospitals to the surgery centers. So this was a very compelling, innovative product. It was FDA approved in late 2012. I started using that technology in probably first quarter of 2013, so 5 years after Mako. And the technology was great in as much as bone preparation was accurate, the component positioning and sizing was very accurate, but it had some issues. It wasn't as efficient as I would have liked. After you did the tibial bone preparation with a 6 millimeter burr, you'd have to take a rasp and smooth it down a little bit.
All right. Yeah.
There was a lot of thenar cramping from holding the device. And if you were doing 4 or 5 or 6 of these in a day, there was a lot of hand fatigue that came with that at the end.
Sure, you need a hand surgeon on call for you. Right?
That's right. And with that product, we had to stand on a foot pedal. So I had developed over the course of several years terrible anteromedial tibial pain from basically standing on my right foot the entire case. And I'm sure if I got an MRI, I would have had massive bone edema
right
in that area. So while the results were good, and we had some radiographic data, which was very compelling, and then clinical data started coming out that was also very compelling and showed better early recovery compared to conventional, and improved functional outcomes at a year compared to conventional, I got a little restless again. So, that took a period of several years. But towards 2017.
Well, when did this technology become Navio?
2013.
Okay.
2012, it was released as Navio.
Also, I want to point out to everyone, if you have questions, you can put them in the chat and I'll call on you to ask them. I do want to make a couple of call outs. Sorry, Jess. I want to make a couple of call outs to Matt Barber, big LinkedIn star. Kevin Plancher's here, Fred Kushner. And if I forget a bunch of other people, I apologize, because we're quite a lot of people. But if you have any questions, put them in the chat. We'll run them by Jess, and we'll have an open discussion about that. Okay. All right. So Jess, you got restless again.
Got restless again. And then I started thinking about several things. One is whether there was another robot on the horizon that might be better for me ergonomically. We did a study at some point, actually after I got restless, we did a study to look at the ergonomics of the system from a postural perspective and also from a cardiorespiratory perspective, and found that, contrary to my hypothesis, I actually expended a lot more energy using this particular robot than I did when I used conventional tools. There was more cardiorespiratory strain, heart rate, respirations, heart rate variability. They were actually less favorable with this robot than I did the unis with conventional techniques. And with this particular device, in my case, there were postural aberrations, so low back strain. So a lot of the ergonomic concerns that I had were now being borne out with quantified data.
Right.
So I was looking for maybe some other technology. I wouldn't go back to a CT-based system.
Right.
I'm starting to think of other technologies that might intrigue me, something that was a little more surgically efficient and a little bit more ergonomically favorable. And then I also started thinking about other applications. So in about 2016, I read an article that for me was a big epiphany. So there was an article about a mathematician named Abraham Wald. Abraham Wald was a college professor during World War II, and he got called in by the military brass because they wanted him to help them with a problem. Their concern was that fighter planes were coming back from combat missions with bullet holes riddled throughout their fuselage and their tails. And these military commanders wanted Mr. Wald, Professor Wald, to figure out a solution for them so that they might be able to reinforce the plane's fuselage and tails without compromising their ability to fly combat missions. And he thought about it for a little while, and he said, your concerns are misguided. It's not the planes that are shot up in the fuselage and the tails that should concern you. It's the planes that are shot up in their noses and their engines, because those are the planes that aren't making it back. So I read this and I started thinking about robotics, because that's all I do these days. And I thought, you know what? Maybe our approach to robots, at least vis-a-vis total knees, is a little bit misguided as well. You know, there was some data that came out of Asia Pacific looking at Robodoc, for instance.
Okay, sure, yeah.
And they had 10-year data that showed when the robot was used for total knees, there was really no improvement in functional outcomes and no improvement in durability at 10 years. So for many years, I really thought of the robot as just being a niche technology for a niche procedure, and that being unicompartmental knee arthroplasties. But once I read this article, I thought, well, maybe equivalence in outcomes is okay. So maybe even if we can't measure functional improvement or improved durability with the robot, maybe there's still a role. Maybe there's just a change in paradigm that we should consider. And, you know, as we started to think about shifting more and more of our total knees into surgery centers,
Right.
obviously space requirements, you need reduced inventory. There's not space for sterilization. So maybe the robot was a vehicle with which we could get more total knees into the surgery centers without all that extra inventory.
Right. Right.
And maybe the robot would help us ergonomically. With the one robot, I didn't find that to be the case, but I thought there must be other robots that, for me at least, might be more ergonomically favorable. But obviously, we have to be able to control the costs. And maybe there's a different way that we can look at costs. Maybe it's not just the the big capital expense of the robot, maybe we should look at the per case costs and the episode of care costs.
Sure, of course. Yeah.
And then, there's a big interest in kinematic alignment. Well, how can we dial in 2 or 3 degrees of tibial varus with conventional instruments and be accurate? I don't think we can, but maybe these robotic technologies get us there. So as I thought more and more about this Professor Abraham Wald, and then started thinking about the potential expanded role into total knees, I became more enthusiastic about finding a robotic technology that I felt could also be used effectively in an ergonomically sound fashion in total knees, so that I could use it beyond the 70 or 80 or 100 cases per year that I was doing in terms of knees, and do it for a larger volume of cases.
It's interesting. I want to just interrupt for a second. A couple of things. I just noticed Jan Koenig is here. I'd love to hear some words from Jan and some questions. Jan being one of the most early adopters of robotics and a leader. So thanks for coming on board. And one other thing, there is a call out to Justin Williams, who is a resident, who is our 200th registrant today. So Justin is going to get a JOEI mug in the mail if Justin texts me his address. I just want to put that out there. If I'm gonna run a game show, Jess, I might as well do it correctly.
That's one way to get.
Thank you very much, sir.
Time in.
All right, Justin, text me your address. Okay.
Will do. Thank you, sir.
All right. Good. I only have my family call me sir, but it's okay. So Jess, you made the jump to the ROSA.
Right.
Okay. Advantages?
So there were several. One is I was really intrigued with the fact that ROSA came into the market at the larger, to attack the larger problem, that is total knees, rather than going into it at the uni space and then maybe expanding to totals. They went right to totals to really refine their system for total knees and then re-engineer it for unis and other applications. So I like the fact that I could start using it potentially right away for total knees. I also really like the fact that they decided to robotize a cutting guide rather than robotizing the cutting tool, whether it's a haptically controlled saw blade or a burr that was controlled by modulating the speed or the exposure. I really like the fact that we could use a conventional saw, which for most of us is efficient, it's ergonomic, and I thought the process of robotizing the guide is very smart. And actually, it's what Jan Koenig's group had done years earlier with the Omnibot. And I think that's a very practical approach. When I played around with the system in the lab before I made any decisions, I found for me it seemed more ergonomic. Didn't put much strain on my back, didn't put strain on my shoulders. And it's also been very easy to teach. And it was very clear that we could use this as a teaching tool to help our fellows and residents understand how to balance the knee, what the different techniques are for making our cuts to achieve balance. And that continues today, even now a year and a half after I adopted the ROSA robot for clinical use. And then one of the more intriguing components of this system, which is still evolving, was the fact that it was the first of all the robots to incorporate artificial intelligence into the system. So with this particular system, you can make your proximal tibial cut, your distal femoral cut, achieve your balance, and then use that to inform the rotational position of your femoral component and where to make your femoral cuts. For me, it takes a lot of the thought processes out of it.
Right.
It's much more simplistic, as sophisticated as that body of work is, for the surgeons, I think it makes it extremely simplistic and user-friendly. So that for me was very attractive. As I get older, I'm looking at preserving my mind, not straining my shoulders, not
Lots of
hurting my
luck.
back,
Yeah, lots of
and
luck.
that worked perfectly. The other really cool component of this system, and again, it's ahead of their time, but I think others will follow suit. And in fact, there are several in the space now, but they have a very broad analytics kind of ecosystem where you can use the various inputs that we make during the surgery, like how do we make our cuts? How do we balance our soft tissues? And those are all captured by the system. And then we can compare that with functional outcomes that are achieved in the postoperative period. And that data can be captured with a smartphone care management platform or other ways of collecting our data.
Right.
It can all be synthesized as part of a broad, intelligent platform that Zimmer Biomet has. And from that, my hope is that their digital library will ultimately be used to decide which of those intraoperative decisions are optimal to optimize postoperative outcomes. And then maybe that would inform further artificial intelligence protocols and
Right.
parameters that are built into the system to
Sure.
basically do more and more of the thought work for us and the different elements of the surgery for us.
So I'm gonna at 8:30. Zimmer is advertising tonight. I just want to make sure we have the Zimmer people on because they get a few minutes to talk about their technology. You guys on?
Yes, I am there. I have the slides ready.
All right, there you go. All right, things are working, Jess. I don't. I'm like amazed. Okay,
Right.
Pierre, thank you.
Can you guys see my slides?
Yes.
Yes.
Right. So thank you, Dr. Kirschbaum, for allowing us to present a little bit about ROSA. My name is Pierre. I'm director of robotic R&D at Zimmer Biomet. So I've been in these technologies since the last 22 years. Before we talked about ROSA, and I think Dr. Lonner did do a very good job at introducing ZBEdge. ZBEdge is actually our ecosystem of solutions. So ROSA is not just a standalone robot, it's integrated into the ecosystem. And our goal with this is really to transform orthopedic care by unlocking insight. And we are able to unlock those insights because all those applications are meaningfully connected in terms of data exchange. So that's the first thing we are trying to do. And a good example of that is Walk AI that was presented on October 6th at this forum. That is our first artificial intelligence application that allows us to predict, like, at 20 days or 15 days to predict what's going to be the patient mobility at 90 days. So we are able to identify early on patients that are not going to do so well. So you guys are able to reach out to them and maybe do some more follow-up. The other aspect is to allow you to access a dashboard that combines the pre, intra, and post-operative data in a very user-friendly screen. And this allows you to create your own custom registry. You can benchmark these techniques you are doing. And so this is very powerful. And I think Dr. Lohner explained very well, like, the advantages of this technology. Now let's get into ROSA. So first, we like to say that there are 4 strategic pillars of ROSA. First, it is surgeon-centric, accurate, efficient, and data-driven. So by surgeon-centric, we mean that we are able to adapt to various workflow. Our intent when we designed the system is we never wanted the surgeon to have to change the way they're doing things because they're doing robotic. We instead allow various options in the system to accommodate personalized alignment, measured resection, gap balance, advanced ligament balancing. So depending on what the surgeon wants to do, the system will tailor its workflow to that specific procedure. Of course, like, all those systems are more accurate than traditional instrumentation, but ROSA is accurate in terms of resection, but also in terms of soft tissue management. We are able to predict, like Dr. Lonner explained, what's going to be the residual laxity once the component is going to be in place. And this is very important in order to tackle that, 20-25% of unsatisfied patient after total knee replacement. The system is also very efficient. Like throughout the design process, we really looked at how can we make like ROSA, or how can we make robotic total knee replacement very efficient? And an example of that is the fact that we are using cut guide. We could have used burr, we could have used various cutting technology, but we realized early on that using a normal saw with intelligent navigation of the cut guide was the most accurate and most efficient way to do total knee replacement. We have both image-based and image-free options, and our image-based option is based on a X-ray protocol that converts 2D X-ray to 3D model. It's called X-Atlas, and again, it's very efficient. It doesn't require any CT or MRI. There's a reduced number of landmark and reduced instrumentation. And then in terms of data-driven, I think we did talk a lot about that earlier on. So it's connected to the ecosystem, and all the companies are talking about ecosystem, but in our case, like it's really there, it's available today, and we already have like predictive AI tools such as Walk AI available today. So in terms of image-based versus image-less, I'm showing like two different screens. We're actually changing our image-less screen with the new version that's going to come out to market, but we are allowing image-based and image-less. And the image-less navigation is not like a light version with less feature. It's exactly the same feature with exactly the same accuracy. It's just we are not displaying the 3D model. Here is how the balance prediction work. So basically you are going we call the evaluation panel. So there's a range of motion and knee state evaluation of the knee. We calculate the gap opening and extension and inflection. And then we are able on the planning screen to actually show what's going to be the residual laxity once the component is going to be in place. So not only we are balancing gap in terms of cuts, but we are also including the ligament opening. We are allowing the surgeon to pick the point, like intraoperatively, the point that they want to use for resection as an example. And we believe this is very important. So instead of relying on an engineer or a technician landmarking a 3D model somewhere in an office, we really believe that, as an example, in the case of a localized defect on the tibia, we should rely on the surgeon picking the right point they want to use for the resection level. Now, I just want to show some ways on how the system is working. So basically, once the plan is defined, we send the robot to position, and the surgeon can gently bring the cut guide against the bone at the right location. It works like this for both the femur and tibia. And once the cut guide is at the right location, of course, when you are moving it, the cut guide stays on the cut plane. So it allows you to pin the cut guide in a more medial approach, as an example, depending on the type of incision you're doing. And also with this intelligent cut guide navigation, we're able to follow the bone movement as it's shown now on the screen. So when you're pinning the cut guide on the bone, if there's a slight movement of the bone or the cut guide, the robot will compensate for that. So these are key features. So it's not only about positioning a cut guide in space, it's a lot about intelligently navigating its position. So just to finalize this discussion on ROSA knee, I'd like to highlight 5 clinical outcomes. We have various papers that are proving these outcomes. So the first one, obviously, ROSA is highly accurate. It is more accurate than conventional instrumentation. We do see some early improved outcome at 6 to 12 months, leading to better patient satisfaction, and it is easy to integrate in your workflow. There's a minimal learning curve of around 10 to 15 cases, and ROSA does facilitate complex cases. So with this, I'd like to thank you very much for this opportunity.
Thank you, Pierre. Thank you. I want to pivot the discussion a little bit, Jess. A lot of people have talked about persona IQ and connectivity. When I was at Orthopedic Summit, Dr. Plancher's amazing meeting, I was able to give this talk on the need for digitization across cross connectivity across all orthopedic encounters. And I only showed a slide because I think it's a cool video. But one thing I talked about was patient reported outcomes versus patient source or patient generated outcomes. You know, we're able now with Persona IQ to get information about what the patient's doing rather than, you know, patient reported outcomes. And also, what we're kind of looking at in the Holy Grail is connecting all these pieces, the Persona IQ, the ROSA, and I have another slide here. This is my circle of technology connectivity. I'm involved in a company called Gate Science, which gives pain management data that the patient doesn't have to report on. You can have a robot, whether it's a Stryker or a ROSA. You can have the Canary. You can have a track patch, and all these things start talking to each other. So, Jess, what do you think about this? Where this is going now, and whether or not we can take the patient subjectivity out of some of the outcomes?
Well, you know, I think anything that requires thought and effort is gonna fail. People won't adopt it, and you'll get very little compliance. So I'm very intrigued by products for patients which can collect their data, functional outcomes, and other data points passively. That's one of the nice things about a device like Canary that can track step counts and, you know, and range of motion, and the sky's the limit, right? If you can use a technology like that to detect early loosening or temperature changes that might portend infections, well, I think it's great.
Yeah.
And the same is true with tools that we use as surgeons during surgery. If we can use a device that somehow takes some of the effort away from us, it will make us more durable,
Yep.
less fatigued. And I think there's some benefit. You know, the incidence of, I've become particularly interested in the issue of ergonomics, because 50% of orthopedic surgeons, 50% maybe of joint replacement surgeons, have musculoskeletal pain. A third of them have severe pain. Many of them lose work. Some require surgery to treat those ailments. So if we can somehow incorporate some technology to be protective of us, I think it's great. We're actually doing a study now. We found in my first 20 cases with ROSA, we did the same ergonomic study that we had done with Navio after I had done 1,000 of those cases. And even during my learning curve, I exerted less physiologic stress and strain, less cardiorespiratory strain. Even calorie expenditure was less after the first 10 cases using this new device compared to conventional. And, you know, I think it's important for us to think about our patients, our staff. We've just done a study starting a study looking at the ergonomics of the technology for my surgical technicians that work with me. And my gut feeling is that they'll expend less energy on themselves, right, with robotic technology as well. And I think that's true with any of the robotic technologies where our technicians are lifting fewer trays, and can be a little more stagnant during the surgeries. I think it's important that we look out for them as well.
Yeah, I wonder if Jan Koenig, if you could comment. You made a comment about the savings about imageless technology. You're still around. Maybe you want to comment on that if you can.
Well, first of all, Jess, thank you so much for coming tonight. This is a great journal club hour, learning so much about your pathway. It really mimics my pathway through robotics, and we've learned a lot of the same things. I've always gone towards imaging systems for two reasons. One, cost, and the other, radiation burden. So I think that's the way to go for the future. And the fact that we're talking about soft tissue balancing and inverse kinematic approaches and stuff, I think that's very important. Jess, what do you think about conventional versus robotics? Are we ever going to prove that it's better one way or the other?
It's a challenge. The problem is that we do a really good job with our total knees. And we know now that a total knee, even if it's less optimally aligned than we would have thought based on our old parameters, as long as the knee was balanced, the results were still pretty good. Look at the studies that have come out of Mayo, for instance, on that topic. It might be that some of our metrics of analyzing functional outcomes are not sensitive enough to detect some of the issues. But what I tell my patients, because I think it's important for us to be honest with our patients, is I tell patients that even though I'm using a robot for my total knees, I won't necessarily say it's going to improve the outcomes, even though there are some studies that show improved outcomes. What I tell them, though, is that I know I'll improve the alignment, will reduce outliers, and maybe there will be some functional improvement that, at least as of right now, we can't measure. But maybe there are other things that we're not looking at yet. Maybe something like Canary will identify some improvement, but also maybe, even though our function is the same with the robot, maybe because of the improved alignment and improved soft tissue balancing that compared to conventional, maybe our outcomes at 10 years will be better. The problem with the Robodoc series, the 2 or 3 of them that had come out looking at 10-year survivorship, is that Robodoc prioritizes bone resection, but has no protocol in its system to quantify soft tissue balance. It's quite possible, and I think we're starting to see this in some of the registry data coming out of Australia, for instance, in systems that prioritize both bone resections and soft tissue balance. I think there's improved durability, and the registries are seeing fewer revisions in those cases that were done robotically compared to conventional. I don't know if that's with all robots. I do know there was 1-year data in the Australian registry looking at ROSA, for instance, that showed a reduced failure rate. There was similar data, registry data, with the Navio Uni system that also showed a reduction in failure rates at 2 years. But those two systems prioritize the soft tissue balance as much as the bone resection. And, most systems now do that. So maybe at 10 years, we'll see a difference in durability with the robot, even though we may not see dramatic functional benefits compared to conventional.
One thing I talk about around the country is using the robots to get rid of early failures, because there have been early failures reported all around the country for malalignment and for imbalance, besides infection. And just in my personal series, I just haven't seen the early failures. We all get an occasional infection that needs to go back. And I had a patient fall down a flight of stairs, but I'm not seeing the loosening that we've seen in the past for total knee. So I'm pretty happy about that. Thanks, Jess. Right. What a great hour, and great paper you wrote too. That's outstanding review.
Thank you.
Jess, you talked about the idea of the early failures, and I was just wondered if there was such a thing as an A surgeon, a B plus surgeon, a B surgeon. Do you think the robotics are able to take a B+ surgeon and turn the results into an A? Is that one of the great advantages?
Yes, particularly in unis. I think the robotic systems have neutralized the effect of inexperience. There's so much data that has come out where a critical volume, annual volume of unis is necessary to be considered a really good uni surgeon, whether it's 20 cases or 50 cases, whatever it is, there's some number of unis that need to be done by someone to basically make them a competent uni surgeon. Yeah. And I think the robotic technologies have neutralized the effect of inexperience. I don't know if that'll be the case with total knees, because most people are getting a lot of experience training in total knees, but certainly with unis, where there's such a tight window of accuracy that's necessary to improve the outcomes. I think the robots have helped that. We're actually about to get an analysis from the AJRR looking at total knee and uni outcomes in the American registry. And it's going to be subdivided by high experience, high volume versus low volume for both unis and total knees, with and without robotic technology.
That's great. So yeah. There's a question from Masha Damanis. Do you want to ask your question yourself?
Yeah, sure. I mean, it's tangential. So I think it's a really interesting question, Dr. Kirschenbaum, that you asked in terms of like, does robotics help elevate from a B surgeon to an A surgeon? And sort of in that world where, we often hear that, 80% of the surgeons are, 80% of surgeries are done by, surgeons who do less than 50 or 20 a year, and that is mind-blowing. Nobody wants a total knee done by that kind of surgeon. But I guess the corollary of that is that we're now shifting from like doing the surgery itself to the preoperative planning piece. And my question is the learning curve lower, easier for a low volume surgeon to learn preoperative planning, because that's a new skill that now surgeons have to acquire?
It's a great question. So I think some of the systems which require you to actually think about the planning in advance with a CT scan, for instance, can be very helpful in helping people understand some of the important elements of preoperative planning for conventional techniques and methods of total knees. But I actually have some concerns about too broad an adoption of robotics in training programs where residents need to learn the basics of the surgical techniques using conventional instruments. And I know of several places where the residents are not exposed to any conventional methods for total knee replacement. We've interviewed a few for our fellowship over the last few years, and I was stunned to hear that there are some residents who've never done a conventional total knee. Now, I've been doing a lot of robotic cases for the last 14 years, and there are cases where a pin will get loose or a fuse will blow, or there's just something that doesn't look right, and I'll abandon the case, and take out conventional tools. And, in those cases, I wish I had learned preoperative planning conventionally, and I wish I had learned conventional techniques for total knees and, maybe partial knees as well. So it's a little beyond the scope of the question you asked, but
no, I appreciate it. I mean, I think that confirms it's not a panacea to, I think we still think that we should shift to some consolidation of doing the procedures by the surgeons who should be qualified to do them, is I think probably the consensus in this virtual room.
Yeah, I think the basics are all very important. I'm okay if someone wants to really study knee replacements, for instance, and learn the basics and then transition to to robotics. But they need to know the basics first. They need to know how to plan their cases first. And then they need to know what kind of planning needs to go into the robotic technology. And then they need to spend some time in a lab learning the technique on cadavers first before they start their obvious learning curve on patients. thankfully, I think with regards to most robotic systems, which are fairly straightforward and intuitive nowadays, the learning curve really has more to do now with surgical times and less with achieving some accuracy. And hopefully the companies are doing a good job training people. I'm actually more concerned about people I've heard of from around the country and even some partners of mine who become, they don't want to lose a patient to a surgeon who's offering robotic technologies. So even though they don't routinely do robotic surgery, once every 3 or 4 years, they might do one because they don't want to lose that patient. That actually concerns me more than someone who's trying to break into the field, who's trying to amass a critical volume of cases, because once they're through the learning curve, they should be okay. Right? I mean, I think in general terms, total knee replacement surgery is not rocket science. It's not brain surgery. It's why I personally didn't become a brain surgeon, because I needed something like knee replacement surgery to get me through my day.
You wanted a patient to walk also after the
Right.
surgery. That was
Right.
the other thing. I do want to make a couple of comments. A little shout out to Russell Bodner, who's on. Russ, thank you so much for coming on board. I know you're very busy, so hello to you. There's a question from Roman De Salva. Roman, do you want to ask that question yourself, or do you want me to ask it for you?
Hey.
Yeah.
No, I'm just kind of curious how you think with recent technologies, things have been changing quite a bit over the years. How do you think that's going to affect the future of joint replacements?
It's going to continue to evolve. Moore's law shows that every 2 to 5 years, there is a dramatic change in technology in terms of its response time, in terms of efficiencies, in terms of the capabilities. I can't fathom necessarily where the technology is going to be in 5 to 10 years. I know it'll be leaps and bounds beyond where it is now, whether there's more artificial intelligence incorporated into the processes. I would think so. I would hope so. But I'm not sure exactly where it's going to go. I think the challenge is going to be to train people on the basics before getting too far along into these new technologies for the issues that we just discussed.
Yeah. That's great stuff. We're sort of at the end. We can go for a couple more days on this. Just some final thoughts that you may want to give us.
Well, I guess I'd say that it's a very interesting space. I think most of the people that are tuned into this probably have experience with robotic technology or are interested in getting into it. I think it's a very interesting, innovative space. And I believe that unlike other technologies that have come and gone, this one now, this class of technology, robotics, has now been around long enough, 15 years or so, that I think they're here to stay. So I look forward to seeing how they continue to evolve over time. The other thing I would say is that as I transition from Mako to Navio and now Rosa, for me, it feels a little bit like fate. And I'm someone who believes in fate and karma. So Zimmer Biomet bought this company called MedTech, based in Montreal and maybe Montpellier, France as well. And they came to the table with this brilliant Rosa robot. In about 2008 or so, Ira, you might remember, maybe some of your other viewers might remember, that Zimmer rolled out at the Academy a robot called Bridget.
Yeah.
And, it was a little bit ahead of its time. It probably wasn't all that practical for the minimally invasive surgery that was really evolving at that time. But it was an interesting foray into the space. They never really commercialized that Bridget robot. The reason I say this for me is fate is that my mother's name is Bridget. And her mother, my grandmother, her name was Rosa. So for me, this was meant to be.
Verche. Yes, absolutely. It's great. So I'm going to close it out. I want to thank everyone, Dr. Jess Lonner, special thanks, and to all the people who participated. This was really a wonderful evening. Thank you, everyone.
Thanks, Ara. Thanks, everyone, for chiming in.